Okay, hi there. I'm going to make a start now. So I'm just hoping that everybody can hear me. If so, can people just say yay or nay, if possible? Oh, they can hear. You can hear me, great. Okay. What I'm going to do is I'm going to unmute everybody. So in other words, I can hear you as well as you can hear me. All right. So hopefully that's going to be okay with you lot. If you don't want to be heard, then obviously do. Okay, we know. I presume you don't. Okay. Anyway, thanks again for everybody for coming in and spending your Tuesday evening with me on this. It is much appreciated, and I can see a couple of new faces here as well. So for those of you who don't know me, my name is Dementia, one of the professional sport pharmacists, and actually I am the professional sport pharmacist at Pharma Plus. And this is part and parcel of one of the services that Pharma Plus actually provides its members. So we do this every month. If you want to, there's some videos from previous sessions that we've had on the website. So if you do need to have a look at them or refresh your memory, whatever on that, they're on there. Today we're going to be talking about quite a new topic which has come out, and that is the NPC Key Therapeutic Topics. Now this particular session is going to be quite intensive. Unfortunately, I couldn't think of any other way of providing you with all the information that you need on this particular area. So as a result of that, I'm going to try and be as quick as possible. Not so that I want to confuse you anymore, but I know that the last thing you want to hear is me droning on for hours and hours on end. So I'm going to try and be as quick as I possibly can. I promise you that. And also, the end of this particular session, what my hope is that you'll have a much more better idea of what this particular area is. And not only that, but how it can influence and affect your own practice as well, when it's likely to do that as well. Okay, so I'm going to move on. Oh, by the way, if anybody, just a couple of ground rules or things that you need to know. This session is being recorded, so do bear that in mind. I'm going to be putting that onto the website as well for others. And if you do need to talk to me, feel free to interrupt me. I don't mind at all. You're more than welcome to if you don't understand anything. There should be a chat window. If you haven't got a microphone, there should be a chat window as well. So you can type in your questions and I'll be able to respond to that on that as well. I'll be able to see it on my screen too. Okay, so I'm going to move on now. Okay, now, what I'm going to do is I'm going to start off by doing something slightly different. I'm going to show you what the NPC document is. So if I write out NPC QIPP Therapeutic Topics on Google, okay, you're going to see quite a few entries, as you can probably see here. All it is you click on this one here, npc.co.uk, QIPP Key Therapeutic Topics. And what we're going to be discussing is this document here, okay? And this one was available in February 2012. It's the 4th version, and it's generally updated on an annual basis. So this is really the document that we'll be discussing. It's fundamental to the sorts of work that GPs will be doing and what medicine management teams will be doing throughout the year. So moving swiftly on. Oops. Okay, so the NPC stands for the National Prescribing Center. The document we'll be discussing is the Key Therapeutic Topics, the one which I just showed you. It is essential reading for pharmacists. It is very important that you do understand the basics behind it, because these are sorts of things that GPs as well as medicine management teams will be focusing on this year. And this particular document is, I know it says V4 on here, which is this one here. But in actual fact, it's it is actually the second version. The first 2 or 3 versions are only minor amendments. This particular version has a whole different set of different things in it as well. And that's the reason why, one of the reasons why we decided to do this as a specific session. As I said earlier, PCTs will be concentrating on this throughout the whole of this year. And as I said earlier on, there have been additional parameters that have been added, additional topics have been added. Now, there's one thing that we're going to do a little bit of work on, and that is the prescribing comparators. And I'm not going to go into what it is now. You'll get an idea of what it is that I'm talking about at the end of the presentation. But this will give you an idea of how different surgeries compare themselves to other surgeries and the PCT in general. But I'll be going over that in a bit more detail a bit later. I don't want to overwhelm you with this one yet. So, that gives you a bit of the background as to what we're going to be doing. Now, what are the areas that this document will concentrate on? And as you can see here, there's a whole different number of areas that the document looks at. Laxatives, the RA, that's actually renin angiotensin. Don't confuse that with rheumatoid arthritis. I just realised what it looks like. That's renin angiotensin. Lipid modifying drugs. We'll go over each one in a bit more detail a bit later. Highdose inhaled corticosteroids, hypnotics, low-dose antipsychotics for dementia patients, first-dose antidepressants in adults with depression or generalized anxiety disorder, antibiotic prescribing, 3-day courses of trimethoprim for uncomplicated UTIs, that's urinary tract infections, the use of Minocycline as well, type 2 diabetes, NSAID, and wound care products. So it's a hell of a lot of different things that this document is going to be concentrating on this year. And a lot of these things are new. So, for example, laxatives is new. We've got another one on inhaled corticosteroids, which is new. We've got hypnotics, which are new. We've got, I think, antibiotic prescribing, which is new. That's new. Minocycline is new. Wound care products are new. So there's a lot of new things that have been added in this time round. Now, before I move on, does anybody have any questions, or does anybody want to stop me for anything at all at the moment? No. Okay, right. I'm going to carry on then, but do feel free to stop me if you do need me, yeah? Now, what I'm going to do is I'm going to go over each one of these in turn. And it's going to bore the hell out of you, but unfortunately there's no other way which I can think of going over each one with you. So please do bear with me. It will make sense at the end, and you'll understand why it is that we're going over in so much depth. The first thing that PCs will be looking at is laxatives, and quite rightly as well. And this is something which I don't think you're going to be able to do too much on. All this particular area is that they're going to be looking out for laxatives as opposed to the long-term use. They're going to be concentrating on the short-term use of laxatives in patients. So really, there's not much in this one. And also with children, they'll be looking at children, making sure they're in line with NICE guidance as well. Again, I'm not going to go over that in too much detail now. But really, with laxatives, there's not much there that really you can help with, apart from obviously the over-the-counter sales. So really, I'm not going to labour on this one too much. What I am going to labour on is the renin angiotensin drugs. Now, this is an immense area which has been in the QIPP objectives for about 2 years now. And believe it or not all practices and not all PCTs have implemented this, and hence the reason why it's still carrying on. Now, this particular area, if you read the document that we discussed a little bit earlier, is going to be going over three areas in this particular category. Now, for those of you who are not quite clear on this, renin angiotensin drugs are all those drugs, antihypertensives, things like, for example, ramipril, losartan, valsartan, candesartan, lisinopril, all those sorts of drugs which affect the renin angiotensin system. The first thing the PCs are going to be looking at, and the chances are most of these have already been done, is what we call the ARB to ACE switch. In other words, what we're looking at here is we're going to be looking at switches from, say, for example, drugs such as irbesartan or valsartan, for example, over to an ACE inhibitor. Okay, so we're looking at, say, for example, things like ramipril and lisinopril. So we're looking at a direct switch of patients from irbesartan, example, to ramipril as another example. And all this sort of work is going to be going on in the background in the GP's surgery. Another bit of work which is currently being done is this one here, what we call the ARB to losartan. Now, for that, for example, what we're looking at is an expensive ARB, such as, for example, valsartan or irbesartan, and switching patients who are on those over to losartan, which is a much cheaper ARB. Theoretically, it shouldn't be a problem. The research suggests that the effectiveness is very similar to one another, and hence one of the reasons why this bit of work is being done in GP practices at the moment. Now, one for you to be aware of is candesartan. Needless to say, the patent for candesartan is going to be expiring in April 2012. So all I can say here is I don't know why they're focusing on losartan. They really ought to be also looking at candesartan as a potential switchover as well. And I think you'll probably find that a lot of patients are going to stay on candesartan now. So the sorts of things you'll be experiencing are patients being switched over from more expensive ARBs such as irbesartan and valsartan over to candesartan and losartan. And this is a huge area. For example, I did a bit of audit work in our GP practice last week, and this particular practice was able to save around about £8,000 simply by switching these patients over to losartan. So it's a huge amount of work and a huge savings, and it's something that that is not going to go away very quickly. So something for you really to bear in mind. Okay, any questions on that before I move on? No? Okay. But remember, there's a chat window. For those of you who don't have a microphone, feel free to type in there as well. So, huge area. I'm going to move on now. Lipid modifying drugs. Right, this is, again, probably a bane in most pharmacists' sides. Again, this has been done for about 2 years, and there is still a huge amount of work in certain practices that needs to be done. Now, there is two parts to this audit, two parts of this work that the GPs will be looking at. The first one is switching patients from atorvastatin and some of the more expensive statins, such as rosuvastatin, over to the cheaper statins, things like simvastatin and pravastatin. Now, like the candesartan issue, remember that the Lipitor patent is going to be expiring soon. Well, it should have expired 6 months ago, but for obvious reasons it didn't. And that's going to be going in May 2012. So heaven knows what's going to happen to this particular audit. I still expect it's going to go through, but it's something for you to bear in mind. You probably will see a number of atorvastatin patients still on there now, because of the fact that GPs will be a bit reluctant to take them off because of the patent expiring. But what you will find is this one here, something called ezetimibe monotherapy. Now, the research, for those of you who are not aware, ezetimibe is another drug which can be used to reduce cholesterol as well. By monotherapy, what I mean is that it's used on its own as opposed to with another statin. So normally what you'd find with ezetimibe is you would find it being co-prescribed with a statin, such as simvastatin. The research has indicated that the monotherapy, in other words, the ezetimibe use on its own, is actually not that great. It doesn't really produce very good results. So what they'll be looking at is patients who are on ezetimibe on their own and looking to possibly switch them over to atorvastatin. So that's another bit of work that's going on in the background as well. So what you might find in your pharmacy practice is the number of ezetimibe patients being taken down, and possibly the number of atorvastatin patients might either remain the same or might slightly decrease. I don't know which way it will go, but it's just something for you to bear in mind. Okay, any questions on this one? Am I boring people to death? Probably. Okay, I'll move on then, yeah? Now this is a new one for the QIPP objectives. It is called the Highdose Inhaled Corticosteroids. Now, by high dose, what I mean is concentrations corticosteroids probably in excess of around about 1,000 to 2,000 micrograms of dexamethasone equivalent. So what I mean is not just simply the one puff twice a day of the 50 microgram dexamethasone or Clino inhaler. What I mean is the really sort of like high dose stuff. You're looking at the serotype at the high 250 or 500 microgram doses. It's those sorts of concentrations that we're looking at. And what happens, well, what usually happens in a GP practice and is that you get a situation whereby patients are put on high doses of corticosteroids to control their asthma, but they are not stepped down. In other words, they're not reviewed on a regular basis. And what happens there is that for a long period of time, they end up on a high dose of inhaled corticosteroids. That's not very good for the patient. It has all other effects upon the body. It has effects upon the bones. It has effects upon other parts of the adrenal suppression, etc., all these sorts of things as well. So what the GPs are going to be doing now is they're going to be reviewing patients who are on high-dose corticosteroids, things like 250 micrograms of serotype or 500 or those sorts of doses, with a view to reducing that dose to a lower dose to make it a little bit more acceptable for the patient in the long run. This is quite a complex audit. It's not very easy to do, and it does require some specialist knowledge as well. So bear in mind the fact that it's very likely in the near future that you will experience a reduction in the sort of volume of the high-dose corticosteroids that you will be dispensing in the future. So it's something that will affect your dispensing practice as well. Okay, so that's okay. Any questions on this one before we move on? No. Okay, right. Please feel free again to stop me at any time. Okay. The fifth one, as we discussed, was Hypnotics. Now, there's going to be this is something I think pharmacists could probably help with as well. It's a very simple, and it could be something that you could do as a clinical audit as well as part of your clinical governance requirements of the pharmacy contract. First of all, the important thing is there's no real difference between the Z drugs and those short-acting benzodiazepines. Now, with the Z drugs, what I mean are things like Zopiclone, as an example. Now, there are other ones as well. I think Stilnox is another one as well, Zolpidem. So all those sorts of Z drugs, there's not really any difference between them. They're also very expensive as well. And the short-acting benzodiazepines, what I'm looking at there are things like diazepam and possibly those sorts of drugs, mainly diazepam. I think lorazepam might be another one as well. And what they're proposing to do is to use the lowest dose for a maximum of 4 weeks. And it's only to be used in patients with severe insomnia, which is affecting their daily life. And this is quite a good clinical audit for you to do in a practice. So what you could do is you could look at those patients who perhaps have just started on a benzodiazepine or a Z drug and make sure that they do only use it for a maximum of 4 weeks where possible. Quite a simple audit, and I'm pretty sure that the GP will be quite happy with you doing that as well because it helps them with their objectives as well. Okay, any questions? No, okay. Right, I'm going to move on. Now, this one is quite a surprising one, and it was quite surprising when I read the figures as well. This is and actually, having said that, yesterday there was quite a lot of information that came out on dementia and how much it's going to be a national priority and how they want to tackle the issue of dementia generally. And this falls on the back of that as well. Now, some stats that you might be quite surprised with. Anyway, a quarter of all patients with dementia have these sorts of antipsychotics prescribed. So things like procyclidine and other sorts of antipsychotics are being prescribed. However, only 1 in 5 of these will benefit from it. So that's 80% of patients prescribed antipsychotics are not benefiting from them whatsoever. So there's going to be a huge effort now to tackle this particular area. Now, the reason is that it's often used as a first-line behavioral therapy modification when it really should be used as a second line when other measures have been used. So this particular indicator is one whereby you're going to have a lot of patients who don't need to be prescribed antipsychotics who are being prescribed it, or for the wrong reasons as well. And those figures actually did surprise me when I read them. And they're all in that document that I pointed out to you earlier. Now, do you want to take a little break? Now, any questions on anything so far before I move on?
Can I just ask about these antipsychotics and dementia?
Sure.
I think this is actually quite a big topic, and for any of the pharmacies who do nursing homes, care homes,
yeah.
I mean, there's really, really poor prescribing out there.
Yeah.
I personally feel very sort of unsure about this topic.
Exactly. I think
there should be some sort of behavioural therapy and trying to manage these patients.
Yeah.
But it's very hard as a pharmacist to sort of start giving advice to people about how to handle dementia patients.
It's not. Yeah. I don't think it's your job either to do that.
And stuff like that.
Yeah. I don't think it's your job to do that either. It's
you're also trying to up, aren't you? Trying to help these patients. It's quite tough.
Yeah, and also for the people who actually prescribe this as well, it's difficult at the end of the day as well. I mean, what do? You've got somebody who's quite aggressive at times as well. When is the border being broken essentially? So, I mean, I wouldn't expect a pharmacist really to do an assessment of this, but it's probably something that you may want to be well aware of, because this is something that a GP could actually raise with you in the future. And perhaps
I have had that situation. I have had a GP raise it with me because he's taken over a home that I used to provide for, and saying, look at all this poor prescribing. I was nothing ever done about it. And it sort of makes me feel really bad. I think, oh God, I never really, said anything. But it's really hard as a pharmacist to sort of
exactly. Yeah, I completely agree with you.
I'm wondering if you could possibly do this as a topic for a webinar in the future.
Yeah, I can certainly.
Because there's a big spread of these drug patients and loads of issues, and it'll be worth knowing which of the licensed ones you can use, and how long should you try for.
I can certainly do that. I mean, it is a huge topic as well. Yeah, I mean that can be. I mean, if that's a request, I can certainly put that through as well, and do a much more detailed webinar on this one. I mean, again, as I mentioned earlier, it's a huge topic nationally now as well, especially with the raised conscious awareness as well, especially at Whitehall a couple of days ago. So I don't see this particular topic disappearing in the near future, especially when you see the figures that have been churned out. I mean, 80% of these patients are not benefiting from it. I mean, the other thing. I mean, I think there's another thing.
How pharmacists can help with.
Yeah. Yeah, I mean, I can think about it. I mean, there's certainly things that we can do in the pharmacy. I think these are the sorts of things that we can actually train carers on as well, to look into as well. But I do have various papers that I'm more than willing to share on some of the work that I've done in care homes on this particular area as well. So, yeah, I mean, that can definitely be a topic that we can discuss later. Does that help you?
Thank you.
Yeah. Okay. Brilliant. Okay. Okay, excellent. Anything else? Okay, we've got a few more to go. So I'm going to not necessarily rush through these, but I'm going to go through these a little bit faster pace now. First choice antidepressants in adults. Now, you probably see a lot of SSRIs out there. The first one that they're going to be prescribing now is sertraline. I mean, that comes as no surprise to me. I presume there's probably in certain areas high prescribing of other SSRIs and other antidepressants, but the first one they're going to be looking at is sertraline now. So you're probably going to experience, if you haven't done so already, a much greater usage of sertraline from your pharmacy now. So not a huge issue there. Now, this one is again, oh, pardon me, sorry, something's happened to my computer. That's better. Okay. Now, this particular one is a topic that's come again from last year. It's something which hasn't really had much of an impact really on last year's objectives, and that's probably the reason why they've continued on with it. They're looking into reducing the two main broad spectrum antibiotic drugs, quinolones and clindamycin. You're probably well aware of the fact of MSRI, and these two particular drugs do promote MRSA even. Quinolone is a particular problem, and what you'll probably find is a huge reduction, or a much greater reduction in the prescribing of things like ciprofloxacin and other quinolones in the near future as well. And this is possibly something that you could work with a GP on. I mean, I don't know how you would, mind you. You could probably do an audit on the number of patients who are prescribed ciprofloxacin and maybe have a chat with a GP about it later. I mean, it's just something that it's not really on the priority list of GPs at the moment, in all honesty. Now, with this particular topic, is a new one. 3-day courses of trimethoprim in uncomplicated UTIs. You probably experience in your pharmacy a huge variety of different lengths of period of time for a UTI. I mean, I've seen prescriptions for 5 days, for 7 days. 3 days is actually good enough, and any longer than that could promote resistance as well. So for those patients who have got a normal tract, who are not pregnant, who are between 60 and 65 and have got normal kidney function, will generally tend to be prescribed 3-day courses of trimethoprim. Not any longer, I mean, not longer than that, not 5 or 7, but 3 days. There is an alternative called nitrofurantoin, which can be substituted for the trimethoprim, but it is more expensive. And again, as with the ciprofloxacin and the quinolone and the clindamycin issue, broad-spectrum antibiotics tend to be avoided now through the C. difficile infection and MRSA. So you're going to find a lot more prescriptions for 3-day trimethoprim coming into your pharmacy from now on. Okay, I've got a couple more left. 10th one was minocycline. Now, there's actually a huge shift now away from minocycline. You're going to find a big reduction in the use of minocycline in the pharmacy now. The guidance has been revised, and in actual fact, the minocycline can be potentially quite harmful. The main side effects, or the more serious ones, are things like hyperpigmentation, hepatitis, autoimmune hepatotoxicity. Try saying that again. I'm not going to do that. Lupus-like syndromes, and there's actually quite a lot of other nasty potential issues with this. And in 2009, there was a Merck update that came in, and this particular Merck update suggested that there is no use, well, basically it's not really recommended for the use of acne anymore, when before it used to be one of the first 9 drugs. So think about it, you've got a higher incidence of adverse drug reactions with other tetracyclines, and there is an insufficient evidence of one tetracycline over another. And looking at a lot of the potential harm that minocycline can do, I think you can probably safely say that the amount of minocycline you would be dispensing in the near future is going to be minuscule. So it might be an advisor, it might advise you to probably run down your stocks on that one as well, because I don't think you're going to get many more prescriptions of that coming through in the near future. Okay, so that's minocycline done. Now, type 2 diabetes. Now, this particular this particular area has been revised slightly, and it's been extended from last year as well. And there's going to be 3 main areas that the GPs will be looking at. Now, the first one is the use of long-acting insulins, and to be honest with you, as a pharmacist, I'd be very reluctant doing any work on changing patients in insulin. That is something that a specialist nurse or somebody should really be looking at. But in terms of a stock point of view, the MPH type insulins, so things like Humulin N, isophane, those sorts of insulins, you'll probably be finding more patients on that one in the near future. There's also something called the blood glucose test strips. That's what BGTS stands for. There's been a lot of work that's been going on with GP practices to reduce the number of blood glucose test strips that are being prescribed. And if you think about it, each box costs around about £30, roughly speaking, give or take. The nice guidance, well, not nice guidance, but generally the guidance tends to suggest that a person who may be on metformin or maybe a sulfonylurea of some sort should really not have more than about 1 box every 3 months. Now, that's generally the sort of guidance that most PCs have been giving. So really what's happening here is that you're going to get a lot of patients, a lot of GP practices are reviewing their blood glucose test strip usage and revising it downwards. In other words, they're going to be issuing more prescriptions at 1 every 3 months rather than one every month, or, I mean, I did another audit a couple of weeks back, and one patient was actually being prescribed 4 every month for some bizarre reason. But you will see a general decline in the number or the volume of glucose test strips you'll be dispensing in the near future. Now, I'm not going to be going over the use of newer agents. We did that last month. For those of you who are new coming into this, if you do want a little bit more information on some of the newer agents that have been used for diabetes, then do check on the website, and you'll be able to find the video on that one. So I'm not going to go into that one a bit more detail, not in any more detail. Any questions on this one at all? No. Okay, right. You'll be lucky that there's actually another 2 more slides on these particular areas, so we're almost there. The NSAIDs, the non-steroidal anti-inflammatory drugs. Now, the NSAIDs, they're quite topical, really. There are various NSAIDs that are used for different types of conditions. Now, the problem with NSAIDs are that they have GI issues. In other words, they have a habit of causing ulceration, all other manner of nasties in your gut. And they also have cardiovascular issues as well. For example, diclofenac has a much higher risk of cardiovascular problems, in other words, of heart attack, those sort of things, stroke, etc., as does etocoxib as well. So really, what's going to happen now is I think you're going to be finding a general decline in patients being prescribed diclofenac and some of the other non-steroidals like indomethacin, as an example, with a view to moving them on to ibuprofen and naproxen. Ibuprofen is much gentler on the stomach. Naproxen in patients who have got cardiovascular issues is much safer as well in patients, and at these sorts of doses as well. So I think you'll generally be seeing a decline in the use of non-steroidals generally, but you might find these particular ones, naproxen and ibuprofen, increasing in the near future. Part of the other bits of work that they'll be doing is another bit of work which I suppose pharmacists could actually help with, is looking at non-steroidals, but making sure that people are being prescribed PPIs who've got omeprazole and lansoprazole at the same time. And also, and that could be quite a nice little clinical audit that you could do in your pharmacy too, again, which will help the GP as well. And they're also going to be reviewing drug interactions. One particular interaction they'll be looking at with a lot of enthusiasm is the ACE and the non-steroidals as well. This particular one has quite a significant renal issue as well. Another has effects on the kidney, and a lot of the GPs will be looking at this one, or a lot of pharmacists working in GP practice will be looking at this one with a view to either, probably with a view to removing the NSAID if possible. So that's really the sort of work that's going to be going on with NSAIDs in the near future. Okay, and finally, we've got the last one, which is wound care products. Now, for those of you who've been stung by PCTs, on-POS systems, or central ordering systems, this probably won't be so relevant to you. On the other hand, for those of you who haven't, this probably will be quite relevant to you. Most PCTs will be going and developing something called a formulary now. So it's a list of drugs that can and can't be prescribed in primary care, or generally should be prescribed in primary care if you've got the option. They're quite detailed as well, so if you haven't done so already, it might be an idea to talk to the PCT to see if you can get your hands on the formulary. Now, the formulary will have something, actually it should be minimum, that should be maximum, sorry, I made a typo there. The maximum dressings quantity prescribed. So in other words, the formula itself will have a limit as to the number of dressings that should be prescribed. So for example, if it says you should only be prescribed 5, chances are you probably won't see a prescription for 10. And there's 3 types of dressings that are probably going to go out of fashion very, very quickly. Those are the silver dressings, the iodine, and honey dressings. I mean, I've never seen a honey dressing, mind you, but heaven knows what they look like. But the silver dressings especially, those are going to go out of fashion very, very quickly by the look of it. They're very expensive, and they're generally frowned upon at PCTs as well. So if you've got a stash of silver dressings in your pharmacy, chances are if you can get rid of it as quickly as possible, I would suggest you do that, because you're not going to be able to get rid of it in the near future. So those are the sorts of wound care products that are going to be targeted from the GP practice point of view. Now, I'm going to quickly go over a quick refresh. Now, we've targeted each and every one of these areas: laxatives, renal angiotensin drugs, lipid-modifying drugs, inhaled corticosteroids, hypnotics, antipsychotics, antidepressants, antibiotic prescribing generally, trimethoprim, minocycline, diabetes type 2, NSAIDs, and wound care products. So we've gone over very, very briefly the sorts of areas that are targeted in the QIPP objectives. Before I move on to the final 2 or 3 slides, does anybody have any comments that they want to ask before I move on, or want to ask anything? So I have gone over this very, very quickly, and sorry, does anybody say anything?
Yeah, I ask about the wound care products?
Of course, yeah.
Did you say there's some sort of organisations that are doing it centrally?
Yeah, I mean, there are, okay, if you happen to be in with a difficult PCT, shall we say. I know, for example, NHS Buckinghamshire does this, and there's a few other PCTs around which do it as well. What happens is they've centralised the purchase of dressings. In other words, they bypass the pharmacist in terms of the dispensing side of the wound care products, and they order everything centrally, which in actual fact has made the situation worse rather than better, because they've been unable to negotiate very good prices. But that's what's happened. So if you are in an area which does that, then there are a number of PCs which do that. This probably won't affect you very much. Yeah. Yeah? Okay. Anything else? Okay, right. Now, if you remember earlier, I said something about the comparators, and I didn't really elaborate on very much on that. Now, I'm going to spend the final few minutes, and I have stuck to my time. I've got another 5 minutes left, which I'm trying to plan in. I'm going to spend a few minutes on what the comparators are. Now, by the name, you can probably figure out that it's for comparison purposes, and you'll be right to think that as well. A comparator is basically a number that can be used to compare a GP practice with another GP practice in terms of their prescribing, or a GP practice with maybe a PCT, or maybe a GP practice with a national one, and with a national comparator. So really all it is, it's a number that's given to a particular practice to allow it to be compared with the same sort of review or same sort of area as another GP practice or another PCT or another national figure, for example. And what I'm going to do is each one of these areas tends to have a comparator. There are a few which don't, but the majority of them do. So, for example, the renal angiotensin one has one. The lipid modifying drugs has one. I think the high-dose corticosteroids also has one as well. I'm not too sure about the hypnotics, but most of these areas have got a comparator. And what I'm going to do is I'm going to quickly show you how those comparators are calculated and how they can actually be used. So a comparator, and this actually could be quite useful when you talk to a GP to know what their comparator is. If they're actually useless at a particular area, so for example the wound dressings, which they're probably likely to be, you could use that as a form of evidence to actually help them with a particular area. So if they happen to be useless at their, I don't know, let's say the hypnotics, then you could possibly help them with that particular area if you wish to go down that route. So the comparators are actually available from the PCT. They've got a whole list of these particular numbers that you can request. And as I said earlier, they're used to compare what should be prescribed. Sorry, I just started coughing there. They're used to compare what should be prescribed and what should ideally not be prescribed. And I know that's very poor English, but I'll tell you what. I'll go over an example with you in a minute to have that calculated. And they're usually expressed as a ratio. Now, if that hasn't confused you enough, this probably will confuse you. Now, let's give you an example calculation. Now, what I'm going to go over is, where is it? It's this one here. I'm going to go over a specific example from the lipid-modifying drugs. And if you remember correctly, the sorts of work that we'll be doing, that the GPs will be doing, is they'll be trying to reduce the ezetimibe prescribing, and they're trying to reduce the atorvastatin prescribing, and increase, therefore, their Simva and their pravastatin prescribing. Okay, so that is what we're looking at the moment. So how is the comparator actually calculated? Now, let's give you an example. Let's say, for example, a particular practice has prescribed 200 items of ezetimibe, atorvastatin, and rosuvastatin. These are the expensive cholesterol-reducing type drugs. If they also prescribe 1,000 items of all the other statins, so for example, simvastatin and pravastatin, the way we calculate the comparator is very simple now. So what we do is we actually use the numerator as the cheaper of the thing, in other words, the one which we want to compare. So we're comparing the amount of simvastatin and pravastatin prescribing compared to the amount of all of the cholesterol reducing drugs altogether. So in other words, 1,000 plus 200. So in other words, we're working on a ratio of everything here. And that works out to be 83%. So that is simply a very simple way in which a comparator is actually calculated. Now, this particular practice has got a comparator of 83%. You might have another one which has got, say, 85%, another one which has got 80%, another one which has got 60%. And now you can probably see how each practice can be compared to one another. And this particular example is something that is used in all of, or most in actual fact, of each of the topics that we discussed earlier. So you can now see that you can target particular areas of a GP practice that are actually rated poorly in comparison to other GP practices or in comparison to the PCT average. And this is quite a powerful method that PCTs use in order to come down on GPs as well. So what? So this is going to be the final slide now. And it's going to be the summary of the whole of the presentation. So hopefully you've got an idea now what comparators are and how they're used and how you should be possibly talking to the PCs to get your hands on these comparators so you can compare what your local practices are doing. So really, what these areas are, which we discussed, the 13 areas, are really areas that the PCT is going to be concentrating on the next year. And they're going to be using up a lot of resources to meet particular targets here. So they're going to be hiring in external consultants, they're going to be hiring in other medicines management pharmacists to actually come into GP practices and doing this sort of work. So if you're that way inclined, you could actually use yourself, possibly even go to a GP practice and do some of the work for them and be paid for it. It might be worthwhile talking to the GP concerned, or so the PCT concerned, to see whether they'll be willing to fund it. And there may be a possibility they can do that. The second thing is that it will affect your dispensing practice. I mean, some of the things I've discussed will certainly affect the sorts of things you'll be dispensing in the next year or so. And bear in mind also the patent expiries that are going to occur in the next couple of months. A particular example will be candesartan and atorvastatin as well. And finally, it is an opportunity to work with your practices as well. Now, I know a lot of you are quite unsure about how this is how you can actually go about doing this, but the conference that we'll be running in May, I'm going to be running a little session, probably about an hour or so, as to how you can conduct an audit in a GP practice using a system called EMIS. And that's going to be something that you can use to then build in an audit for these particular areas as well, so you can work with the GP that way. That really is about as much as I'm going to be talking about now. And I know I've gone on and on today, and it's a lot of information to take, and I can appreciate that. But just as a final thought, does anybody have anything else they want to say before we switch off? Anybody? Okay, it doesn't look as if there's anybody there. Okay. Just a final thought then, before you all log off, we have got our conference on the 13th, I think it's the 12th and 13th of May. It's a weekend, it's a Saturday, Sunday. You're going to all get the agendas very, very soon as well, and part of that is going to be some new services that we're developing. We've got some new services, paid services in actual fact, on dermatology that's coming up, and also on another one on atrial fibrillation, which is quite an exciting one because it's probably the first time anybody's done that in the UK in the pharmacy as well. So that's something that we're going to be launching at the conference, and I would encourage you to come in. We've got quite a few expert speakers coming on. We've got a session on EPS2 as well. So please look out for the agenda that's coming through, and if you can make it, that'd be really, really helpful as well. So do try and make that if you can. Okay, so I think I'm going to switch off for now. If there's anything else anybody wants to ask, what I'll do is I'll give you my email address. It's pharmaplusltd.co.uk. If you've got any questions on this or anything else in the future, then do let me know. We're going to be putting this video up on the website, and you can find the website here, pharmaplusltd.co.uk. That's our website address. And that should be up there in the next couple of days or so. Okay, so I'm going to log off now. Thank you for everybody coming along. I know it's been very intensive today, but hopefully you've gone away with a fairly good idea of what's going to happen in the near future in terms of prescribing. Okay then, thank you very much now. Take care now. Bye.
Thank you, Japan.
No problem. Bye now. Bye.
Everybody